Now you can hear me. So, Assalamu alaikum everyone. So thank you Ali and Naeem for setting the stage. Today my task is to convince everyone that DPP inhibitor should be a second line agent in type 2 diabetes. However, I must admit that there is no single agent which you can call it that it should be the second line agent after metformin in all patients. We have to go individualized patient-centered approach in which we have to look either the drug is effective and also the patient characteristics. So it's depend upon either the patient had established atherosclerotic cardiovascular disease, either the patient have risk of atherosclerotic cardiovascular disease. We need to look at either the patient have chronic kidney disease or heart failure, and risk of hypoglycemia. So that's one thing which is very, very important. Its risk of hypoglycemia is very important and impact on the patient. For example, the risk may be different for a 30 or 40-year-old person than a risk to an 80-year-old who live alone. So when we choose any medication, we have to choose the one with the lesser risk of hypoglycemia, because hypoglycemia got a lot of cost, which is not obvious from outside, but once the patient is admitted or patient had hypoglycemia, that can have a lot of impact. Then the impact on the body weight, the risk of the side effect, and the cost. Ali have very mentioned about the cost, and I agree with Ali. For example, sulfonylurea, I will call it like a Suzuki car. So if you get a Suzuki car, you will get the Suzuki benefit. If you get a Toyota or a Land Cruiser, you will get the Land Cruiser benefits. But they all are effective. They all do the same job. They all work. They all improve HbA1c. But there is some benefit which you get with newer agent, and there are some benefit which you can have with the older versions. But they all are effective. So you can't say one should be superior to other. It depends on the patient risk factors, which you make a decision. So metformin is the preferred initial pharmacological agent for the treatment of type 2 diabetes. Once initiated, metformin should be continued as long as it is tolerated and not contraindicated. Now, the patient with established risk factors or established cardiovascular disease or kidney disease or heart failure or GLP-1 analogs or SGLT2 inhibitor with demonstrated cardiovascular benefit is recommended. This is as per ADA guidelines. For patients without those risk factors, a second agent to add to metformin is not yet guided by any evidence comparing across multiple classes. As per ADA, we can add sulfonylurea, we can add glitazone, we can add DPP4, we can add SGLT2 inhibitor, GLP analog, or basal insulin. As I mentioned, this all depend upon patient characteristics, patient circumstances, and the effectiveness of the medication. It's a busy slide, but it is a model-based meta-analysis where they looked at different classes of, so this is a meta-analysis which different drugs, all anti-hyperglycemic, and they are color coding. So the gray is for metformin, the green is for DPP4 inhibitor, then there is a GLP-1 analogs, the orange one is for your SGL2, and then there is a glitazone at the lower end. So you can see here their effect on HbA1c, the weight, and the hypoglycemia. So when we compare DPP4 inhibitor and SGL2, they both have improvement of HbA1c around 0.7%. And when we talk about sulfonylurea and glitazone, they definitely they are more effective in terms of HbA1c. However, when we look at their effect on the weight or the hypoglycemia, then certainly the DPP4 inhibitor and SGL2 are better in terms of weight loss and hypoglycemia. As I mentioned, hypoglycemia is very, very important. And you can see here that with the sulfonylurea, that's a major risk. Graphical representation regarding the effect of on HbA1c with DPP4 inhibitor and SGL2 inhibitor. And you can see they have they are equally effective. Sorry, I don't have the slides for sulfonylurea. So dipeptidyl peptidase 4 inhibitor. Their mechanism of action is prolongation of activity of glucagon-like peptide, gastric inhibitory peptide, as well as other incretins by restraining their breakdown. The member of the DPP4 inhibitor are sitagliptin, vildagliptin, sexagliptin, linagliptin, and alogliptin. According to clinical trial data from development of various DPP4 inhibitors, they can cause reduction of around 0.74 depending upon their use as a monotherapy or in combination with other anti-diabetic medication. So we know it is effective. Now, DPP4 have a neutral effect on patient weight and a very low risk of hypoglycemia. This has studied even in patients who are during the fasting, and they found that the risk of hypoglycemia is very, very low, even in patients during fasting during the Ramzan. DPP4 inhibitors are metabolized by renal excretion. Therefore, it is necessary to adjust their dose in patients with moderate or severe renal impairment. So, for example, sitagliptin, if your EGFR is more than 45, there is no dose reduction needed. If it's 30 to 45, you reduce to 50, and if it's less than 30, you reduce to 25 milligram. So the benefit of DPP4 inhibitor is you can use even in the advanced renal failure. An exception to this is linagliptin, which is mainly metabolized through biliary tract, and a very small fraction being excreted through the kidney, so it can be used in renal failure, although it is not available in Pakistan. So, so we can't use it, although it's a very good agent to use in renal failure. But sitagliptin, you can use it, and other DPP4 inhibitors. Now, coming to the cardiovascular, this is the era where we are talk always about the cardiovascular risk. So cardiovascular safety conducted on patients treated with DPP4 inhibitor suggest a rather neutral effect on cardiovascular event incidence and severity of outcome. There was a severe TIMI trial which showed that sexagliptin didn't increase the risk of cardiovascular disease, but did increase the risk of admission with heart failure. Afterward, there was a meta-analysis which was done, which actually looked at multiple studies looking at the effect of DPP4 on cardiovascular event as well as on the heart failure. And you can see here that this is a cardiovascular neutral drug. There is no increased risk of cardiovascular event with the DPP4 inhibitor. And you can see on this one that they looked at hospitalization for heart failure, which was raised in severe TIMI trial. Even that is not the case. So there is no increased risk of heart failure secondary to it. There is a raised concern for pancreatic adverse reaction with DPP4 inhibitor, since there have been reports of acute pancreatitis. However, analysis suggests that they didn't show increased prevalence of acute pancreatitis as compared to any other anti-diabetic medication. And at this point, it is important to mention that diabetic patients show a higher risk of pancreatitis anyway in comparison to non-diabetic. So because we were comparing these three drugs, so I thought I can just bring out some features for all these three drugs. This slide which I took from ATA, so nothing I have added personally. So let's come to the DPP4 first. So we can talk about efficacy. So it's intermediate. When we talk about hypoglycemia risk, no risk of hypoglycemia or very low risk. When we talk about weight change, it's weight neutral. When we talk about cardiovascular disease, it's neutral. Heart failure, when we talk about, I already touched this subject, the sexagliptin was found to have increased heart failure admission. However, in other studies and a meta-analysis, there was no evidence of such effect. Then the progression of kidney disease, it's neutral. The benefit of DPP4 is you can use in renal impairment as well. Additional comments, the pancreatitis has been reported in clinical trial, but its causality is not well established. and its suggestion is to discontinue if peptidase is suspected. It can also cause joint pains. Now, coming to the sulfonylurea, which Ali have nicely presented, I accept that it got a good efficacy. It have risk of hypoglycemia and weight gain, and these are the two things which we need to really look at. Cardiovascular wise, they are neutral. They also don't have increased cardiovascular risk. Limiprid and glipizide, you have to be careful in renal failure because that can increase risk of hypoglycemia. FDA special warning on increased risk of cardiovascular mortality based on older agents like tolbetamine. So this is not with the second line agents which we use. Now this is SGL2 inhibitor. So efficacy wise, this intermediate hypoglycemia, it doesn't cause hypoglycemia. It does cause weight loss. Regarding the cardiovascular, they do have benefit, EMPA and CANA. Heart failure wise, EMPA, CANA, DEPA, they all have benefits. Progression of kidney disease, they do have benefits. Renal dose adjustment is required. Now, ADA suggests that they should be discontinued before any surgery to prevent potential risk of DKA. DKA risk, all agents have a risk, although it's rare in type 2. There is a risk of bone fracture with canagliflozin. There is a genitourinary infection risk, risk of volume depletion, hypotension with the SGL2. There is increased LDL, and there is a risk of frontal gangrene. That's from ATA.
2 minutes.
So now, while preparing for this, I found a very interesting information which I thought I would share, which maybe we use in future much more. Maybe many people here already know this. So in combination, DPP4 inhibitor and SGL2 can use to improve the glycemic control in numerous patients. And there is a relatively low risk of adverse effect with this combination. So the combination of dapagliflozin with sexagliptin was compared to sexagliptin or DAPA monotherapy, was examined in a 24-week randomized active control study having 534 subjects with type 2 diabetes, previously receiving only metformin. And you can see here, the red one is the combination where there is a sexa, DAPA, and metformin. And the second one, the green one, is sexa plus met. And the third one is, blue one is DAPA plus met. And you can see the combination of DPP4 and SGL2 actually have a maximum benefit in the HbA1c. An interesting point is the inhibitory effect of glucagon secretion. So DPP4 inhibitors cause inhibition of glucagon, as opposed to the stimulatory effect of SGL2 inhibition, because SGL2 called glycosuria, and as a result, there is increased production, endogenous glucose production. So if we use these two together, they can actually regulate glucagon, and that can result in decreased risk of your DKA and urinary tract infection. The study which I quoted that actually showed that there was less urinary tract infection. So with this, I think as a representative of DPP4 today, I can actually if we use these two in combination in future, that might be a very good thing. Now coming back to my original topic, so we have to go for a patient-centered approach to choose the pharmacological agent. And in patient without established or high risk for cardiovascular disease, kidney disease, we should consider DPP4 as an add-on to the metformin, because it has been in system since 2007. So they will be unlikely to have any surprise as compared to the new agent. It is safe, effective, anti-hyperglycemic. With this, I would like to end my presentation. Thank you very much.